Looks perfect now. Thank you.
Okay. Looks okay, right? Okay. So the patient is a 69-year-old woman with history of hypertension, RA, who presents for follow-up. She was complaining of pain and swelling in the left knee, which developed over 1 week, she said, the past week. And at the time of the visit, she was having trouble walking and said she could walk only 1 block, where before she didn't have trouble walking. So as we said, history of seropositive RA. She's on methotrexate, Humira. She's on her blood pressure meds, Hyzer and nifedipine. On physical exam, the remarkable findings is the ontology gait with increased swing phase on the left. The left knee was warm, was tender to palpation, and also had swelling, very noticeable. Some crepitations of flexion extension. The rest of her joint exam was unremarkable. She had some swan neck deformities with which were reducible, but no signs of synovitis. As far as labs, we saw elevated inflammatory markers compared to her prior visits. Now they were higher, both the ESR and the CRP. X-rays wise, so these are the X-rays. We see a little bit of osteoarthritis here, some narrowing of the joint space. And this is the lateral view. And if you look at the lateral view, this is the suprapatellar bursa. And I think you need to see a couple of normal ones to be able to distinguish that there is some effusion here, that this area here, the suprapatellar bursa, is distended and is merging with the quadriceps. And also, if you look at the patella, you see that it's irregular here. So there is some osteoarthritis here, some patellofemoral component. So based on the history, what would be your differential and what would you do next? Just shut it out. These are some options.
Hi. So I think we should first exclude Soberbo's septic arthritis, because just before just assuming that it's acute attack of rheumatoid arthritis or bursitis, infectious bursitis, by just doing TAB and then make sure it's not septic.
Okay.
Then.
So that's exactly, it's the arthrocentesis should be the next. So one thing I wanted to clarify, when I said the bursal, suprapatellar bursa, which is distended, it's like a misnomer, because suprapatellar bursa here it's just part of the synovium here. It's not like a separate fluid overlying the knee. Anyway, so you said arthrocentesis. Arthrocentesis is the correct answer. So we did tab the joint, and analysis showed crystals, and did not grow anything. The white blood cells showed 23,900. So this is consistent with an inflammatory pattern, right? So which crystals would you expect to be positive in this patient? Just anything that comes to mind.
I think in patients with rheumatoid arthritis could have cholesterol-like crystals. But it could also be any other of the crystal-induced arthropathies like gout and pseudo-gout.
Right. No, that's very good. So all those three are possibilities. So what we saw in this case was this crystal. Do you guys know what this is?
The pseudo-gout crystals.
Okay, and how would you describe the morphology here?
It looks like a rhomboid crystal.
Mm-hmm. So it looks rhomboid. This is parallel to polarizing light and it's blue. So the mnemonic is ABC. When it's aligned, it's blue in pseudo-gout. And also you see them, it looks like a rhomboid here, but sometimes it looks also like looks like a road at cases. So I'll definitely recommend that you look at a bunch of crystals, whether it's monosodium urate or this PPP crystals, because they will show you different ones, and sometimes it's not so straightforward. Right. So it also sometimes can be shown as needles as well. So just be careful to not confuse it with monosodium urate. Right. So this patient did have CPPD, right? And therefore the arthrocentesis was helpful. Now I want to talk a little bit about the mechanism here, because it really helps us understand why do you develop calcium deposits in the cartilage, and also how to look for triggers, what type of workup you want to do. So just to simplify it, you just need to know two things. Here we have this pyrophosphate, and here we have the calcium. Any change in these two can cause precipitation of crystals into the cartilage. CPPD includes its specifically calcification inside the cartilage. So what can elevate calcium? Hyperparathyroidism, right? CKD, among others. And what about the pyrophosphate here? You see that the pyrophosphate is inside the chondrocyte here, and it's being sent out by the ENK protein. So there is an ENK protein, and for it there's an ENK gene as well. A defect here, a gain of function mutation, will increase the levels of pyrophosphate, therefore leading to increased levels of calcification. So if you have somebody in their 20s, they come to you, you work them up, find out they have chondrocalcinosis, chances are this is familial, chances are they might have abnormality in this gene. So another cause, so alkaline phosphatase, we check this all the time when we get our LFTs, the CMP, etc. So we usually are worried when it's elevated, right? But what if it's low? If it's low, then maybe this patient has a defect here, so this pyrophosphate is not really being broken down, because that's what alkaline phosphatase does, it takes away the phosphate, right? So with an elevation of pyrophosphate, you have increased deposition of calcium. So next time you see somebody with a very low alkaline phosphatase and they have knee pain, they might have chondrocalcinosis from this process. And you might think, what about magnesium? Where's magnesium here? Because hypomagnesemia can also precipitate CPPD. Magnesium is a cofactor here with alkaline phosphatase. So a deficiency in magnesium can also increase the chance of developing chondrocalcinosis. What about hyperferritinemia? Like hemochromatosis, Wilson's disease? Well, they can inhibit alkaline phosphatase, and therefore you can get this calcification. But you cannot, the increase in iron, the increase in copper can also increase the chance of precipitation by themselves. So that's another part of the mechanism. And once you develop crystals, they are engulfed by neutrophils, macrophages, and then you develop the inflammation, prostaglandins are released. So the whole inflammatory process takes place. Next. So as we said, so for the most part, it's idiopathic. As patients get older, they develop chondrocalcinosis in their knees, and therefore there are a higher chance of developing CPPD. So you can have chondrocalcinosis and not have the disease, meaning you have the calcification but not the symptoms. So if the patient is younger than 55, then we should look for all those things that we just talked about. Higher chance of this being a metabolic disorder. Look for hypomagnesemia, look for hemochromatosis, etc. Hyperparathyroidism, yes, hypomagnesemia, we talked about, hypophosphatasia, joint trauma, meniscectomy as well. So men with CPPD have the highest odds for which one of the following comorbidities? RA, gout, hyperparathyroidism, or hypomagnesemia?
You can answer this poll. I'll give you a few seconds, and when enough participants have submitted their answer, I can display the results. So I'm closing the poll now. We have almost 55% answered, and these are the results.
Okay, great. I think all of those are reasonable answers, but I feel like the majority definitely got it. Hyperparathyroidism, hypomagnesemia is not a bad answer, but I'll explain why hyperparathyroidism is the best. So this was actually, we found this out by a study that was done at the VA, National Cross Study of US veterans, right? So the odds ratio of hyperparathyroidism being associated with CPPD was 3.35. This was the highest, followed by gout, and then osteoarthritis. So those were the highest. But then again, hypomagnesemia is not a bad answer either. We know it. There is an association there. So triggers: dehydration, surgical procedures, Synvisc injection. So when we do hyaluronic acid injections, it has phosphate in it. Therefore, it can lead to precipitation. If you give Synvisc and the next day the patient comes with a swollen knee, just think that it could be an attack of CPPD. So they need to get another aspiration. First, we rule out infection, right? That's always the first thing. IV biphosphonates. So IV biphosphonates have been associated with CPPD. So that's something else to be aware of. Giving GCSF, initiation of thyroxine. So some clinicians may look out for TSH levels because just the patient might not tell you right away that they just got started on thyroxine. As far as prevalence, so to get it in patients younger than 50, it's rare, but then as we go up in age, the chance increases. And then now we're talking about chondrocalcinosis. When we say 30% of the population has chondrocalcinosis, we're not saying they have the disease, but that's the incidence that has been found in X-rays of the knees and the wrists. So the knee and the wrists are the most common sites where you'll see this calcification. The TFCC, which is this triangular fibrocartilage on the wrist, located right by the ulna. And knees is where we see most of the calcification, but they can occur anywhere. Pubic symphysis, including, it can occur in the MCP joints. 20% of these patients with CPPD don't have the calcifications on the X-rays. Therefore, it's important for us to aspirate to find out if this is an infection, if it's gout. In our patient, in the case that we presented earlier, she didn't have calcification. So how to distinguish it with gout? So clinically, CPPD usually takes a little bit longer to reach its maximum effect. With gout, typically we say it takes about 24 hours, and patients usually wake up with a painful foot, they cannot bear weight. And it's usually with gout, if they are in the initial stages of developing gout, it's in their first MTP, is the podagra. But if it's not managed well, if the uric acid levels keep climbing, then in gout you'll see it in multiple sites, and the patient might come with polysynovitis. But with CPPD, it's usually the wrist, it's usually the knee. The patient will come with a swollen wrist, an elderly man usually with a swollen wrist, usually sent to us by ortho to evaluate for rheumatic disease. So that's usually how we see those patients. CPPD can be confused with RA because a lot of times you don't have just one joint, you might have multiple joints involved. Elderly population, they might also have a weakly positive rheumatoid factor. So just be careful to not diagnose patients with RA just because they have a low positive rheumatoid factor. Therefore, joint aspiration is very important. If you can, X-rays are important. Ultrasound is better than MRI. As far as diagnostic tests, I think we mentioned them. All the above. If you think about the causes of it, then you'd know what to look for. So from arthrocentesis to calcium levels to ferritin, etc. So this is an ultrasound for CPPD. And I definitely use the ultrasound whenever I can. If you ever rotate with me, you know that we look into patients' joints. So here we have the calcification right into the cartilage. So that's a distinguishing feature from gout, where you have the double contour sign. In gout, I'll show you another picture, what makes it different. But here, the calcification is right inside the cartilage. The cartilage is all this anechoic region here, and right inside of it is this calcification. And it's interrupted. It's not like one continuous line. And here we have the meniscus where there's calcification. The sensitivity is pretty good, 74. Sensitivity, specificity 77. X-rays, some say sensitivity is 94 to 97. And MRI is less than ultrasound. So I'll definitely get the X-rays first and then look for ultrasound as well. So in gout, I think you might have heard already about the double contour sign, where you have this precipitation of crystals right outside the cartilage, which makes this double contour. You have one contour here, and then on the outside of the cartilage, you have another. So this makes it a double contour. In chondrocalcinosis, you have these calcium deposits that are not continuous, right? So here you have one. I guess it's a little bit hard to tell from this image, not the best image, but there are some calcifications here and there. And here the calcification is right inside the cartilage, which is the distinguishing feature from gout. Dual energy CT scan is a new modality. It's not always readily available. I think they have it at MSH, but so it might be a little bit harder to get it, but you can look for gout, you can look for pseudo-gout, and then the color depends on how they adjust it, right? So in this case, they adjusted it such that CPP crystals will light up as green, but in other ones, they can light up as purple, depending on how they adjust it. And here we have an ultrasound image, X-rays, which show calcification. So you can see how it looks in these three modalities. And here we have the TFCC calcification here, there, and there as well. So just get in the habit of looking at the knee, looking for chondrocalcinosis. Usually it's in the lateral portion, but I've seen it in medial as well. In the TFCC calcification here by the MCPs, usually associated with hemochromatosis, and we have an ultrasound image here. So as far as treatment goes, it depends on the case. If it's one joint or two joints, intra-articular steroids will be preferable. If the patient has polysynovitis, if they don't want any injections, then systemic steroids will be better. You can also treat with colchicine, which is given similar to gout, 1.2 milligrams followed by 0.6 in an hour. NSAIDs can be given at inflammatory doses. So if you give naproxen, should be given at the highest dose, 500 Q12 instead of 250 Q12. So whatever NSAID you give, should give it at the maximal dose. Anakinra help suppress inflammation, and those are given in very rare cases. Hydroxychloroquine Methotrexate, so there are case reports of it. There are some small studies, but no substantial information to say that we should treat with hydroxychloroquine or methotrexate. And when we're talking about those two options, we're thinking about a patient who can present with chondrocalcinosis that is chronic, that has failed NSAIDs, for example, it's not responding to colchicine. So we're talking about long-term therapy in that case, not for short-term flares. So in the case that we described earlier, the patient got the steroid injection after we got the studies, and then when I called for follow-up, she was doing pretty well. Okay, so this was it for CPPD. Before we go into another topic, I just want to ask if you guys have any specific questions for CPPD.
Hi, I have a question regarding the treatment options. So beside the comorbidities that can affect our choice, is there like a specific like the severity of the disease or like to choose something over something else, like steroids and like severe disease versus like NSAIDs in mild or like moderate?
Absolutely. So if the patient has polysynovitis, they cannot ambulate, I'm going with steroids. And this is where every attending might have their own method of how much steroids they give. Some will give just 40 milligrams PO, others will give 40 milligrams of Solimedrol IV, but preferably we want to shorten the hospital stay, right, if these patients cannot ambulate. And we have all the means to take care of these patients if they develop something in the hospital, right? So I'll be a little bit more aggressive if somebody has polysynovitis, they can't ambulate. I wouldn't just give them colchicine, I'll give them steroids, usually IV steroids. But then again, you need to think about comorbidities, and that will tailor your treatment options as well. So there are some other exercises that will help us distinguish about which way to go when we talk about gout. But I usually pretty liberal when treating with steroids if a patient has polysynovitis.
There was a question in the chat. Matthew was asking whether ultrasound is better than MRI for all joints.
So the sensitivity and specificity for ultrasound, some studies show that it's better. So, but the caveat with ultrasound is it's user dependent, right? So whether you have years or decades with practicing ultrasound, or you just took it for the first time and you started to look for it for calcification, that makes a big difference. So I would say that if you are very comfortable, definitely use ultrasound. I would always get an X-ray, but as far as an MRI, I think if those options are not helpful, then you might want to explore other conditions. But some of the studies show that MRI is better. I mean, ultrasound is better than MRI for chondrocalcinosis. Okay, anything else, or should we move on?
I think we can go ahead.
Okay. All right, so we have a 78-year-old woman with a past medical history of hypertension presenting for evaluation of acute onset left shoulder pain for the last 10 days. She reports 2 prior episodes of left shoulder pain and swelling in the last 4 years. The most recent episode was 3 months ago. She was seen by an orthopedist who aspirated the shoulder. Synovial fluid cultures were negative at that time. The fluid yielded 500 leukocytes per milliliter, and she was treated with naproxen 500 milligrams twice daily for 2 weeks with a resolution of symptoms. She reports no recent history of trauma to the upper extremities and is otherwise feeling well with no other current joint pain. She reports no recent fevers, rashes, or travel, and no alcoholic or tobacco abuse. On examination, she is afebrile. She has no rashes. Examination of the left shoulder reveals a large effusion with warmth and tenderness to palpation, but no erythema. She has limitation in both active and passive range of motion. The radiograph is shown. Can somebody read this radiograph? Like, what do you guys see here? Come on, don't be shy.
Christopher, can you help us?
There is destruction of the head of the humerus on the joint. You can see that there is also narrowing. Like, yeah, there is narrowing of the glenohumeral joint with destruction of the humeral head. Guys.
Yep, you're going in the right direction. What else do you see?
So around the shoulder area where the soft tissues are, I can see also like there is opacities around.
Right, and what do you think those opacities could be?
Well, so that could be, it could be inflammation, like I have no clue, to be honest. What could that be?
But
It looks like calcium position.
Can you repeat that one more time, please?
Looks like calcium deposition.
Right. So it looks hyperechoic, right? And calcium deposition, yeah. So going to the question. So if we aspirate this joint and we use polarized light microscopy, what do you think we'll see there? All right, so basically this question is a little bit tricky, I would say, but I know that even MaxApp talks about this, so I thought it was fair. So what we'll see in polarized light microscopy is that we wouldn't see anything in polarized light microscopy. You don't see anything for basic calcium deposition. So you guys mentioned that this seems like a calcium deposit there, which is correct, it is. And but you wouldn't see that in polarized light. In polarized light, for our purpose, we'd see CPP crystals, and then we'd see monosodium urate crystals, right, and other ones. But these basic calcium deposits are difficult to see on microscope, and they can be missed. So polarized light wouldn't be able to tell us. You'll see this thing, and you'll see this if you stain specifically with alizarin red. It's a special stain, and what we see here in red are clumps of hydroxyapatite crystals, which is part of this basic calcium deposition disease, with this halo, like a red halo around. So yeah, so in this case, we have Milwaukee shoulder in this patient. And like you guys mentioned, there is destruction. So it's a destructive arthropathy. We have the calcium hydroxyapatite crystals there that we saw in alizarin red. The x-rays will show erosions, calcific tendonitis of the supraspinatus. The supraspinatus doesn't have great vasculature, which is prone to these calcifications. Arthrocentesis, as we mentioned in the case, showed only 500 leukocytes, so pretty slight degree of inflammation to no inflammation. And as far as treatment, these patients will come recurrently to the clinic. You need to aspirate, treat with NSAIDs. Okay, so now we're going to do a little bit of an exercise. I'll show different crystals, and you can tell me what the morphology looks like and what the pathology could be. So let's start with this one.
Those look like rhomboid crystals, like we've seen in Gout.
So what I'll describe them is they're flat, right? So somewhat rectangular with these notched corners, right? So flat. If you see any crystals with notched corners here, it's probably cholesterol crystal. So that's what we have here. So we have cholesterol crystals. It was already mentioned that you'll see them in patients with RA. So they are polarizable, positive and negative birefringence. As you see, they're like bluish and reddish. So you have these really beautiful colors here, which you see in polarized light. I think maybe this is a little bit too specific, but you should just remember that you'll find this in rheumatoid arthritis. Remember the notch corners and the crystals. I mean, the cholesterol does not come from metabolic cholesterol, right? So this comes from neutrophils. The membrane of neutrophils is being destroyed, and then crystals are released. These cholesterol crystals. And what about this one? First, is it polarized light or not polarizable? We have blue, we have yellow, right? So it looks like polarizable, right? And what about the feature? How would you describe the morphology here? Multi-sclerosis, right? Multi-sclerosis. So acute arthritis, traumatic injury. So think about trauma, think about fractures when you see these lipid crystals. And what about this one? How would you describe them as far as morphology?
They are
Envelope.
similar to the oxalate crystals, I guess, but I'm not sure if we can see those in the joints.
Yeah, right. So they look like envelopes, right? So that's what they are, calcium oxalate. You see them in CKD, ethylene glycol toxicity. I think you guys have a like a nephrolithiasis lecture next, so just remember this one. Yeah. And what about this one?
That's gout. Well, you have negative by refringent needles, but you also have positive ones because they are blue. You have like yellow and blue ones.
Right. Yeah, exactly. So since we're going to start talking about, so yeah, that's exactly what they are. And one thing to remember is that if you find this inside a neutrophil, it's more specific, because some people can have monosodium urate crystals and maybe it's not contributing to the inflammation, but if you see them inside the neutrophil, it's more specific that they are having active disease, because that's how you trigger inflammation. Okay, so some questions on gout. What do you guys think? The prevalence of gout has decreased in the last few decades, or has it increased?
Increased?
Just give it another 5 seconds and then we'll close the poll.
Absolutely, yes. So it's false. The prevalence has increased, and why has it increased? Metabolic syndrome, right? It's on the rise. The population is getting elderly, right? So all those things contribute to rising prevalence of gout. There is definitely association with metabolic disorders. So just something to be aware of. And then which of the following is the cause of urate overproduction? And I didn't put letters here, but just what do you guys think?
All of them.
All of
I
them.
say all of the above.
Okay. Yes. So all the above. One thing I need to mention about fructose is that always ask the patient if they drink sweetened drinks, sodas, because fructose sweetening is everywhere, right? So just make sure, because I had patients that once they stop drinking sweetened drinks, they stop having gout. And yeah, that's something to be aware of. Lymphoproliferative disorders, you already know. And alcohol ingestion, yes.
Sorry, does that mean like eating a lot of fruit is potentially a cause as well?
Eating, so fructose, whether it's a sweetened drink or anything that has higher levels of fructose will
Okay.
can predispose. Yeah. And the events that can trigger gout, alcohol, exercise. I had the patient the other day who said, you know what, when I was before I was overweight, that's when I got my gout attack, because I was telling him, you need to lose weight, it's part of the gout treatment. He was like, when I was exercising, that's when I got gout. So exercise can trigger gout. So stress, dehydration can trigger gout, but make sure the patient stay well hydrated. Surgery, right? And now you tell a patient that, well, maybe we should start therapy, but you also need to follow a diet. They'll tell you, well, I just want to do the diet. You need to explain to them what are the expectations for as far as treating with diet. How low can their uric acid level go if they follow a very strict diet? Okay, so the correct answer is A, but B, I wouldn't say it's wrong. There are reports where they say mostly it's 1 milligram per deciliter, but it can also be 1.5. So if you got B, I wouldn't say that's a wrong answer. So as far as food, can you guys, so we mentioned, right, no alcohol can increase fructose, seafood, especially shellfish. As far as meat also can increase it. So those are things to be aware of, to inform your patients. And then which foods can contribute to lowering the uric acid levels?
You don't have a poll, but please, you can either put it in the chat or unmute. You have some, Fatma says C in the chat.
Mm-hmm. See, so reduced fat dairy intake it's a good answer. I mean, the other ones are also, there's been association with decreased levels of uric acid levels, but then again, tart cherry is kind of hard to find them. So I think all of the above are possible good answers, but reduce dairy fat, reduce fat dairy, it's also a very good one. So as far as characteristics, we mentioned that initially when the person is first developing gout symptoms, they usually have it in their first MTP, so it'll be monoarticular. But if it's not controlled, if it's been occurring for years, then they start developing it in the other joints as well. As far as reaching its peak intensity, it's expected to reach it within 24 hours. Low-grade fever, it's a common finding. Periarticular erythema, yes, and then if you look at the joints of this patient, especially the first MTP, you'll see some desquamation of the skin, which is a result of the inflammation. And then frequency, as we said, the first MTP is the most likely affected first, but then you develop it in your ankle, knee, which would be second, and also your elbow, less likely than you develop it in your wrist or shoulder. At that point, gout has probably been going on for a while and it's uncontrolled. When should you treat asymptomatic hyperuricemia? Never when it's above 6.8 or when it's above 9. See in the chat, see what people say. Above 9, never, yes, never. So never is the right answer. Now, don't confuse above 9. If you have one gout attack and it's above 9, you may consider starting. But if a patient is asymptomatic, we don't just treat hyperuricemia, right? If they don't have anything else. Right. So we have a question now. So we have a 44-year-old man presents to the emergency department for further evaluation of severe recurrent flares on the pain in the right ankle. He's had several attacks per year, mainly in the first MTP and ankle joint. He was on allopurinol, 300 milligrams daily in the past, but stopped it because he thought it triggered attacks. For his current flare, which started 2 days ago, he sought care from his orthopedic physician. Aspiration of fluid demonstrated a white blood cell count of 53,624, with sheets of monosodium uric crystals noted. Culture of the fluid was negative. He received a steroid shot in the joint, but this has not relieved his pain. In addition to gout, his medical history is significant for hypertension, complicated by CKD, poorly controlled type 2 diabetes on insulin, and CHF, with last recorded ejection fraction of 30%. His current medications include carvedilol, insulin, atorvastatin, and enalapril. Relevant labs show GFR 45, A1C 10.3, uric acid level of 6.3. Physical exam vital signs are stable. He's afebrile. He's an obese male in moderate distress who has difficulty ambulating because of right ankle pain. Severe pain is elicited with circumferential palpation of the right ankle joint. Marked loss of passive and active range of motion is noted involving the right ankle. The patient was also found to have non-tender erythema and swelling involving the medial aspect of his right first MTP joint. Which of the following is the most appropriate next step to manage this patient's right ankle pain? A, adrenocorticotropic hormone, IM, anakinra, sub-Q for 3 days, colchicine, 0.6 twice a day for 5 days, D, methylprednisolone, 60 milligrams intramuscularly once. Let's see. B, what else we have?
You can use the poll. You have about 30-45 seconds to answer.
B. Well, we have a lot of future rheumatologists here. All right, great. So that's the correct answer, anakinra. Now, somebody wants to tell us why not colchicine?
Not colchicine because of the CKD that the patient have with his and methylprednisolone just once is not going to be enough to control the inflammation and the gout flare he had. So I think anakinra is the appropriate like anti-inflammatory for his flare at this point.
Okay, any other thoughts?
I thought that it's okay to use colchicine until the creatinine clearance is less than 30, but given that the patient had severe symptoms and he didn't respond to topical steroids, I wouldn't use colchicine for his case. I would either steroids for several at least 5 days or more potent treatment.
Right. So this question is from the boards, right? So they want to make sure that we have some. They'll give you what are the contraindications here, right? So you can pick eventually go to the right answer. So they tell us that this patient has diabetes, right? He's on insulin, uncontrolled diabetes. He already got a steroid injection and didn't really help him. So also has CHF, right? So you have diabetes, CHF. Giving more steroids, giving systemic steroids in this case, which you can do with methylprednisolone or adrenocorticotropic hormone. I have never used this. It's an expensive treatment, and I personally would. I have no experience with it, but it works similar to methylprednisolone. You'd expect the same side effects in a way: elevation in sugars, fluid retention, right? So if they develop hyperosmolar syndrome. So in this case, steroids will be less preferable. Colchicine, so the boards really want you to know the interactions between colchicine and the medication that the patient is already on. So in this case, it would interact with carvedilol. It interacts with most beta blockers. So just be aware of it. And this patient has CHF, so we cannot just stop his beta blockers. It also interacts with calcium.
I think Dr. Koci is having some technical issues. Let's just wait a couple of minutes. Yeah, Dr. Koci is joining in 1 minute. So please bear with us. Thanks.
I think I got it back. Okay. All right, so I don't know where it interrupted. Did we get to?
I think it was a couple of slides before this.
So it was it was right right here. We talked about the answer here, right? Yeah. All right. So the question here is: a 55-year-old man is diagnosed with hypertension. Other than a single episode of podagra 6 months ago, his medical history is unremarkable. He takes no medications. Family history is notable for his father and brother who have gout and hypertension. On physical exam, temperature is 36.6, blood pressure is 152/100, pulse rate is 82, respiratory rate is 14, BMI is 24. The remainder of physical exam is unremarkable. Studies are significant for normal blood, urea, nitrogen, serum creatinine, and electrolyte levels. Serum urea level is 7.9. Which of the following antihypertensive drugs is the most appropriate for this patient? Just shout it out.
Vincent says losartan.
Losartan, yes, because it's a uric. Uric has abilities to excrete the uric acid, so that would be the correct answer here. I'm just gonna move in. So what are the indications to start urea lowering therapy? One, if the patient has any tophi, that's an indication. If they have any radiographic image, so the patient comes with a swollen joint, you want to get x-rays. If there's any erosions, they should be started on uric lowering agent. If they have frequent gout flares, and by frequent, let's say 2 or more, that's an indication, right? If it's just one, that's not a strong enough indication. So it's initiating urea lowering therapy in patients who have their first flare is recommended against per the new guidelines. But however, you have to take the whole picture into consideration. If they have CKD, if the uric acid level is also greater than 9, they have kidney stones, then you might want to consider it at that point. And then again, should we treat asymptomatic uricemia? No, right? So this actually I recommend against in patients with asymptomatic hyperuricemia. What is the preferred treatment? Allopurinol is the first and the second. Why? Because it's cheap, it's effective, and compared to febuxostat, it's 20 times cheaper. And as far as efficacy, it's just as effective. So a common mistake, and you might be tested for this, is that they might give you a patient who's on 400 milligrams of allopurinol, they're still having flares, their uric acid is not controlled. What to do? Maximize allopurinol. You can go up to 800, you can go up even higher, but FDA approves 800. So make sure they're maximized first. And then what to do with colchicine? When do you stop colchicine? The patient needs to be flare-free for about 3 to 6 months. And the uric acid level has to be at goal, because if the uric acid level is not at goal, chances are you're going to change their allopurinol levels, and any change in uric acid levels can trigger a gout attack. So whether that's dehydration or whether it's you starting them on allopurinol, anything that changes their uric acid levels can trigger gout. So be aware that they should be on colchicine while we're making these changes, and they need to be stable for 6 months. What is the target for uric acid levels in patients who are receiving therapy? Less than 6, right? So we should have a goal in mind, and that's less than 6. If they have a flare with 5, you go to 4. They have a flare with 4, you go to 3. So you can keep lowering the uric acid levels. But for us, as long as they're less than 6 and not flaring, we're happy with that. We're not aiming for the lowest uric acid level possible. A patient with gout and uric acid level of 7.5 had 2 flares over the past year despite being on 800 milligrams of allopurinol. What would you do next? Probenecid, pegloticase, or febuxostat? The answer here is febuxostat. If the first xanthine inhibitor doesn't work, you go to another, and the first one should be allopurinol unless there is a real reason to not give it. If the patient has a genetic predisposition, and by genetic predisposition we mean they say they have origin of Han Chinese or from Thailand, then you look for genetic screening for them, for those patients. But otherwise, they should be on allopurinol. That doesn't work. You go to febuxostat before you try these other agents, probenecid, and last is pegloticase. All right. So in a patient who's failed a combination of allopurinol and probenecid and who continues to have more than 2 flares a year and no resolving tophi, what is the next step? So you try allopurinol, you try probenecid, they're still having flares and tophi, you go to pegloticase. That's an indication to start pegloticase, right? And again, we give it only on resistant cases. And as far as treatment, what is the first line of treatment for gout flares? It can be anything. It can be colchicine, prednisone PO with a taper, an IM injection, triamcinolone acetonide, indomethacin, anakinra, as we mentioned earlier, ACTH, which I've never given before. So all of those are options to you. You have to decide yourself. If they have polysynovitis, I'll go with steroid. Usually an IM or IV steroid in that case. And think about, every time you see colchicine, think about interactions. And I don't know if we have the time, but I think we're almost done. So I think maybe we should just finish here. But any questions?
Yep. Thank you, Dr. Koci. If anybody has any questions, please ask them right now. You can unmute yourself.
You can shoot me an email if anything comes up later. I'll be happy to answer your questions.
Matthew is just asking, when should rheumatology be consulted for these cases? I think he's referring to inpatients who are admitted.
Right. So as a consultant, if you have a question, you consult us. That's basically it. Don't even think twice about it. Yeah.
Thank you. Thank you so much. Thank you for joining us, Dr. Koci. For the rest of us, we are going to be taking a short break and then we'll reconvene in a few minutes. All right.